Hello, this is Maria Wright from the University of Pittsburgh DPT program, here to present the current evidence regarding the musculoskeletal diagnosis and treatment of scapular instability. The shoulder complex is comprised of the glenohumeral joint, the acromioclavicular joint, the sternoclavicular joint, and the scapulothoracic joint. All must work efficiently together to achieve normal motion at the shoulder. It is important to note that the scapulothoracic joint is not a true joint because it does not articulate with two bony surfaces. Rather, muscles separate the anterior surface of the scapula and the posterolateral surface of the thorax. The average resting posture of the scapula is 10 degrees of anterior tilt, 5 to 10 degrees of upward rotation, and about 35 degrees of internal rotation. This posture can be highly variable among patients. A broad definition of scapular instability includes any deviation from the following static scapular position. The acromion should be higher than the superior medial border of the scapula. The spine of the scapula should be 15 to 25 degrees rotated in the coronal plane. The medial border and inferior angle of the scapula should be tight against the rib cage, and the clavicle should have a slight posterior rotation in the frontal plane. For the subjective presentation, the patient will present with complaint of pain with shoulder movements and/or weakness of the shoulder. Kibler and colleagues defined scapular dyskinesia as a visual observation of one or more of the following three items below. Scapular instability or dyskinesia is often found with other shoulder disorders. For this reason, the therapist should always investigate the integrity of the scapulothoracic joint when a patient presents with shoulder pain. The following is a list of conditions that may result from scapular instability as well as disorders commonly present with scapular instability. The examination of scapular instability should always include the following three items: visual observation, observation of the effect of manual correction on symptoms, and investigation of surrounding anatomical structures that may contribute to instability. Listed here are the most useful examination tools to identify scapular instability according to a statement released in 2013 by the International Consensus Summit on the Scapula. They are direct observation, scapular assistance test, scapular repositioning test, and the push-off test. Muscle testing, clavicle and AC joint assessment, and postural assessment are additional useful tests to perform on patients with suspected scapular instability. Non-surgical treatment options include various braces to support and improve posture, utilization of kinesiotape to stabilize the scapula, and anti-inflammatories such as NSAIDs or cortisone injections in the case of bursitis. There are few procedures for surgical treatment of scapular instability. If the bursitis cannot be managed conservatively, doctors may opt for an arthroscopic bursectomy. In the case of snapping scapula syndrome, muscles and other soft tissues will rub over each other, causing inflammation. Management of the syndrome involves removing the superior angle of the scapula and reattaching the muscles to the spine of the scapula. When treating the scapula, it is important to have an optimal anatomical base. Any surgical or corrective procedure should be addressed prior to prescribing a rehabilitation program. Scapular instability is largely due to muscle weaknesses and can be treated well with conservative approaches. The upper trapezius, lower trapezius, and serratus anterior all work to upwardly rotate the scapula. The serratus anterior is the primary muscle for scapular stabilization, keeping the scapula tight to the thoracic cage. It is also important to know what stage of recovery your patient is in and gauge the difficulty of your exercises accordingly. Stages of recovery, as well as some common strengthening exercises for the scapular stabilizing musculature, can be found in the PT treatment section of the wiki page. Here's our list of references. Thank you for listening.